So I'll just start. Hello everyone. I'm really glad to be able to give this video to you. I'd rather be there personally, but I think this is a good use of our time so I can tell you a little bit about what we're trying to do at Hemoglobal. And I'm going to start with just introducing our Make Care Fair campaign. We're trying to improve the prognosis for childhood leukemia and thalassemia in Asia. And that's primarily what Hemoglobal does. But just a little bit about the diseases we work in, and then I'll tell you a little bit about our plans. Hopefully we're going to gather some interest in fundraising and awareness from you and others, and I look forward to working with you. So, to start talking first about the disease we primarily work in thalassemia. Thalassemia is an inherited disease of hemoglobin. It's not an acquired disease, you can't catch it, and it's severe in its homozygous form. What's really interesting is that it's not very well known. It's certainly not a household name. If you say sickle cell anemia, there's a lot of name recognition to that. But with sickle cell anemia, thalassemia is one of the two most common single gene disorders in the world. So it's not rare, it's very common. It's mainly common in Asia, North Africa, and the Middle East, but it was common in Europe, related to the malaria infection, which I won't go into now, but it's a very interesting story. And it's a problem because it is an expensive, complicated, and a unique disease to treat. Patients need monthly transfusions, blood transfusions, generally, and as a result, transfusions result in iron overload, and iron overload itself needs treatment. So if iron overload isn't treated, or if the patient isn't transfused, one or both, then they don't survive very long. Now, in higher income countries and richer resource countries, both leukemia, which I won't speak about much today, and thalassemia result in survivals well extending into the 60s because transfusions and iron removing therapy are quite available. So I'm going to tell you a little bit more about life expectancy. Oops, gone the wrong way. So without regular transfusions, children die of anemia in the first decade of life. And that's common in a lot of centers in Asia, as I'll speak to in a minute. But with regular transfusion, they survive. However, with poor iron removal, they get iron overload in their heart, liver, and endocrine glands, and they will die between the age of about 10 and 25. And when I was in practice many, many years ago, we didn't have many people who survived past 25. And now we have patients living into their 60s, probably into their 70s, although it's been a while because the survival is staggered according to what kind of treatments we had. But for example, in Canada, with regular, safe transfusion and available iron chelation therapy, people live quite a long time. But where thalassemia is most common, in fact, where 90% of the people live in the world, that isn't the case. This is a diagram of the global distribution of thalassemia. You don't have to really worry about, this is just showing the different mutations, because there are about 200 different mutations responsible for thalassemia. I'm going to talk about two countries, India and Sri Lanka, in both of which we work, but where thalassemia is very, very common. And I'm going to briefly tell you a little bit about what we're doing. This is myself and Professor Weatherall and our nursing sister in front of the National Thalassemia Center going up about 15 years ago. So when we first got there, we had a very crowded room, literally a long corridor where patients sat, their parents sat under the cots, and it was really quite a dismal setting for looking after it. So we decided to support a National Thalassemia Center, and this is it. I have lots of pictures of it, nice and new, but this is what it was going up 15 years ago. And we then put the lab and the clinic rooms and a playroom, and we were able to establish thalassemia care on a separate setting. And this is what it looks like now. There's a couple of kids, you see everybody's getting transfused, a bit chaotic. There's just a picture of Sri Lanka. And the reason I show this is because Sri Lanka has many, many centers where thalassemia patients are cared for, not all with the same quality, so it's one of the things we want to support and make care equitable. It's a beautiful country full of temples and beautiful produce and wonderful animals. And this is exactly the old thalassemia side with the new pictures, and this is some of the work going on in the thalassemia center today. These are pictures just from the last few summers. So if we turn now to India, because I want to make this not too long, Beta thalassemia, which is the thalassemia we're talking about, is a significant health burden as well in India, but because of the large numbers of patients, it has even more patients than Sri Lanka does. The estimate is at least 200,000 trying to live with thalassemia. The clinics are dismally crowded, and here's an example of it. And here's a slide I want to go through a little bit because it does show what Hemoglobal really is trying to address, which is inequity of care. So we have kind of a saying, make care fair for children. If you look at Canada, every year in Canada, 400 children with leukemia and about 20 with thalassemia present for medical treatment. So those are significant numbers, but every year in India, 8,000 children with leukemia and 10,000 children with thalassemia seek medical treatment. Well, that's related in part to the populations of Canada and India, but if you look at the survival, this is the striking difference. In Canada, it's very rare for a thalassemia patient to die as a child, and acute lymphoblastic leukemia, which is the commonest form of childhood leukemia, has a survival rate well exceeding 90%. In India, and I've written 50 here, but it's more like 40, so I wanted to be conservative, 50% of children with either disease survive past childhood. So it's a 50% mortality, and we think that's unfair. We don't think that children, because of their place of birth, should suffer diseases that are actually curable or highly treatable. The percentage of children with leukemia born in lower income countries is more than 80%, and the percentage of children with thalassemia born in lower income countries is 90%. The deaths in childhood cancer every year in Canada are about 135. The deaths due to childhood cancer in India are 13,000. So when we started talking about this and thinking about this and thinking about the art of the possible, what we could do, if you look at the disparities in income, they're gross. I mean, there's high CEO salaries and high Canadian physician salaries. If you look at the average salary physician working in Calcutta, in the hospital where I work, it's about 17,000. Now I'm going to talk a little bit about what we're trying to support at about 6,000 or 7,000, called the Hemoglobal Patient Ambassador. So I'm going to get into why survival is not as good in India as it is in higher resource countries. And I'm going to have to make this a little bit compact, but it essentially boils down to treatment abandonment. So people say, oh, there's no medicine, or oh, there's no doctors. And I say, no, there's doctors. There may not be highly available doctors, as I'll discuss in a minute. There are doctors, and medical treatment is free. The problem is still that about a third of the patients with thalassemia die before their 18th birthday. And that's because children and their families abandon treatment. So it's called treatment abandonment. And they abandon it because it's just too tough to achieve this kind of success without a lot of support. So, for example, with thalassemia in richer income countries, there's a dedicated doctor and there's a dedicated nurse. There's often a couple of dedicated nurses. There's dedicated social workers and child life supporters and discounted parking and nice clinics and safe blood and available drugs, which are free. And that just isn't the case as I'll discuss in a minute, with thalassemia or leukemia. So we have rich countries, we have beautiful settings, we have glorious atriums, and we have the contrast in Asia, Southeast Asia, where this is kind of the waiting room where one of the patients is waiting. So I'm returning to this. I think I have some repeat slides here. And the origins of treatment abandonment. So if you've never heard this term, which I hadn't heard about 3 years ago, I automatically assumed it was due to lack of resources. And of course it is due to lack of resources, but it's primarily the lack of manpower. So the problem is that I asked my colleague Prantar in India, tell me the truth, how long can you spend with a new patient who's been diagnosed with leukemia? And he said 20 minutes. Now, to understand this, you have to understand what's given to people in richer countries. They sit down with a doctor who explains a devastating diagnosis. Then they meet their dedicated nurse who will be there for 3 years with them. Then they may meet a social worker, or a child life worker, or a psychologist, or a counselor. And there'll be a lot of time spent and a lot of support imparted to this family and their child. But the average physician in NRS Calcutta can give about 20 minutes to that family. So you can imagine the distress of being told this in kind of fast form. I'm speaking fast too, but they are told, okay, it's a fatal disease and you'll have to get treatment for 3 years, you have to travel back and forth, you'll have to leave your village, no, we don't supply you with transportation money, yes, you may get a low white count, you may get infected, your child may be very, very sick. it's all compressed into 20 minutes. It's impossible to believe, impossible for me to believe when I heard it. And anyway, now, so that turns it over to how would you deal with that? And a lot of families think, "Oh, I can't do this, I don't have any support," and they abandon treatment. And doctors may appear to be rushed, because in fact, they are rushed. They don't have any time. I asked how many nurses were in that clinic, and there are no nurses in that clinic. There are people who are actually putting in the IVs or setting up the medicine, but no dedicated nurses. So what do you do? So if you throw money at that, that's going to go into the hospital coffers. It may not be directed at the families and instruction to the families. So we decided to take a little bit of a lesson from how lay health workers have helped people in other countries. So lay health workers go on there and support doctors and nurses when they're there, and act as counselors and psychological support, social support, moral support. And we decided, if that were the case, that lay individuals who might have experienced illnesses themselves would achieve even better success in helping peers. So I asked Krantar, do you have any patients who have survived leukemia or are doing well in thalassemia? And of course he does. He has got good treatment going on for some patients. And I said, well, is anybody old enough to try to take an active hand in clinic and instructing patients and their families? So the answer is yes. So we decided to try to see if we could find former patients who are managing thalassemia well, there's no cure, but not managing thalassemia well, or have survived leukemia, who could take responsibility for families and wouldn't cost very much, cost less than half of a doctor, and would be directed only to this project, only to these families. So we call, as I said, we call them hemoglobin patient ambassadors, and they basically do what every child in the world gets if they're not living in India, which is intense, selective encouragement, explanation, what they can expect, how long is this period of treatment, and then it goes into maintenance therapy and how that works and what they can expect in terms of adverse effects or toxicity, how important it is to comply with the medicine, how important it is to get your blood counts checked. Parents and siblings are obviously very vulnerable to having a child with leukemia or thalassemia, so the patient ambassadors aim to help establish patient and sibling groups, and they basically keep the patients informed, supported, hopeful, and surviving. And so we want to reverse this. We want to make it all different. And we may not make it 90% in the next 2 or 3 years, we're definitely going to make it better. Because we don't think anybody from the area of birth that they come from should be really so disadvantaged with respect to survival. We've got these diseases. These diseases are well on their way to being cured or absolutely adult chronic diseases now. But in India, as I've said, it's quite different. So thank you from the bottom of my heart, from the kids who we're looking after, and please help us make care fair. Thank you.